Welcome to the Pink Pineapple Podcast, where we peel back femtech and take a bite out of more than just the juicy bits.
I'm Claudia, and I'm Emma's partner in Pineapple for this adventure.
And I'm Emma. Together, we're exploring women's health across the full timeline, from first periods to menopause and everything in between.
Each week, we'll dive into the stories, science, and software shaping the future of women's health, from hormones to hardware, fertility to femtech founders.
Think of us as your slightly nosy best friends who just happen to be doctors with a healthy curiosity for innovation.
We'll be chatting to clinicians, creators, and change makers, and yes, asking the questions you actually want answered.
So whether you're out for a walk, cooking dinner, or hiding from your to-do list, join us as we get curious, clinical, and occasionally controversial.
This is the Pink Pineapple Podcast,
where women's health meets what's next. Hello, everyone, and welcome to another episode of the Pink Pineapple Podcast. We are very excited today to have Katherine Church with us. And I'd just like to give you a bit of an intro about Katherine. She is super experienced. She's a digital health leader, advisor, and an advocate for women's health whose LinkedIn posts, particularly around UTIs, inequalities, and the women's health strategy, have resonated with thousands of women online. She's not a clinician, which we absolutely love because we know that her focus is actually on the experience and the challenges that women are having as well. We'll be talking to Katherine about why she thinks UTI care in the UK is failing so many women, what a better pathway could actually look like, and some of the innovations in the space and the hope that they can offer to women as well. And also, most importantly, how policy needs to change if we are going to stop leaving women in pain. So in the second half as well, we obviously want to touch on Katherine's own fascinating journey from, digital health leadership to her upcoming women's retreat in India. And we have just seen a beautiful view from where Katherine is based today. Claudia and I are both very, very jealous. So it's going to be a brilliant conversation. And Claudia, what have you got onto the
I've
desk?
got something for you. So hello, Katherine. It's so lovely to see you. So it's lovely to have you on the podcast. I'm going to do my thing. Are you ready? So let's see if this works. I'm rolling out my yoga mat for anybody that's not able to watch. Oh, this seemed like such a good idea at the time. She's doing Shavasana. That's it. That is today's introduction. I was like, what could I dress this pineapple in to give India retreat vibes, like yoga vibes? I was like, you know what, Shavasana. So here it is for you.
Amazing.
Welcome.
Thank you. Thank you so much for having me on.
And you are probably from the furthest away we've ever spoken to anyone so far, I would say. Right? Distance-wise, Emma?
Yeah, I think you're right. We've had a couple of people, I think, in Europe. We had one potentially in the US, maybe. I'm not sure. Yeah. But yeah, you're definitely up there for a contender for sure.
Brilliant.
But let's get down to business. Let's start with a quick introduction with UTIs or urinary tract infections for those that aren't sure what UTI means, how common they are and how we are kind of treating them currently.
Okay. So UTIs is essentially an infection in the urinary system. So that could be the urethra, the bladder, the urethras, or the kidneys. And the vast majority of UTIs happen when bacteria enter the urinary tract and multiply there. There's about six major kind of groups of pathogens that cause UTIs, with E. coli being one of the leading ones. So that's the dominant pathogen that we're dealing with. However, it could be a number of pathogens causing this. It's a vastly under-researched area. Women's health is vastly under-researched. This is about urine and women and older women, so triple yuck, so very small amounts of research into it. But it's actually possibly one of the most common conditions that women will come across. And it's one of the most common bacterial infections worldwide, which is hugely, hugely important when we think about UTIs in the context of antimicrobial resistance. So in terms of numbers, about 40 to 60% of women would experience at least one UTI in their lifetime. I see Claudia nodding there. The second you say UTI status, you'll see pretty much every woman in your kind of like groups wins at this. So 40 to 60% of women will have at least one UTI in their lifetime. 1 in 10 women will have at least a UTI every single year. And of that, about 20% of women will have recurrent UTIs. So this is UTIs that come back within 1 to 3 months of that first infection. So that adds up to about 400 million infections globally every single year. So that's massive. Also, while we're here, just a little bit about the pressure on primary care. So why should systems care about this? Because it is one of the leading causes of visits for women to their GPs. Emma, you'll find this. So a huge number of visits to GPs, 190,000 hospital admissions caused by UTI. So if a UTI isn't found quickly, isn't correctly diagnosed, if the right pathogen isn't identified and the right antibiotic applied within a fairly timely time span, then actually that can lead to much more serious complications, of which around 190,000 hospital admissions, and that is going up every single year, and we'll come on to that in a reason. 1.2 million NHS bed days. So in a system that's on its knees, we really cannot afford to have 1.2 million NHS bed days for something that could be to an extent preventable and manageable in such an easier way. And in numbers terms, 600 million of cost. And the other thing, just to add into all of that, so it's a massive problem and it's a women's problem. And it's a women's problem in age as well. So of these hospital admissions and cost, around over 60% of them were in adults aged over 70. And of that, again, it's adults aged over 90. And of course, once people go into hospital at that age, the likelihood of them coming out of hospital and being able to lead independent lives is massively compromised. So it's one of these almost like turnkey episodes of health that leads to these horrendous consequences for younger women in terms of discomfort and pain and cost and impact on their lives. And then older women, much more prevalent as we go through menopause. And then, of course, much older women, and then with the impact on hospitalization and quality of life. So it's a big deal. And final bit that I'll add here is the link to sepsis. So in terms of sepsis, so incredibly serious condition that leads to thousands of deaths every year in hospital. Around 30% of sepsis cases are linked to untreated UTIs. So it isn't just pain, discomfort. It could actually be life-threatening and life-ending for women. So it really is a serious, probably one of the most serious conditions that we talk so little about.
You've put that really well, actually, Katherine, like super, super well. And Emma and I were talking about how as GPs, it was such a common presenting complaint, suspected urinary tract infection, the symptoms of, is it not? And also, as you were saying about older women, the symptoms that they would present with, like, for example, it was actually a very common thing to have a woman come in that had a really terrible fall, and it turned out to be because she'd had a urinary tract infection that hadn't been diagnosed or hadn't been treated. Confusion, really common symptom also, so it's not a teeny tiny little thing. Everybody kind of disregards it. So it's just one of those common things, just little. It's common, it's normal, but it's not at all. It's got quite serious impacts for people.
Like you say, Claudia, with regards to the confusion and the delirium, particularly obviously in older patients who are very vulnerable, we find actually often that it can cause like a stepwise decline as well. But when people go home, it can take them a long time to recover from that delirium. And sometimes people never really recover cognitively back to baseline as well. So it's so many of these other impacts, as Katherine was saying, from untreated infection and indolent infections.
Exactly. And the other part of the question was that how is this routinely treated? So in England, we have a scheme called Pharmacy First, which encourages women to go to their pharmacies where there's a triage-based questionnaires. And for following this clinical protocol, if it's seen to be or thought to be an uncomplicated lower urinary tract infection in women who are not pregnant, then there is a standard prescribing of a kind of like broad spectrum antibiotic called nitrofurantoin. And the protocol there is that is prescribed for women for 3 days. And whilst for a lot of women that is successful, so the women, who will have one episode of a UTI will respond well to this protocol. But for about 20% of women, and I'm one of them, I did not. And what happened to me, and this really was, and I didn't think I could get angry about anything more in women's health, having been through surgical menopause and the hell that led through that. I didn't think I could get angry about anything more in women's health. But my experience over last summer, bouncing around pharmacy first, GPs, walk-in centres, NHS 111, led to the conversation we're going to have about broken pathways. But anyway, for 80% of women, go to the pharmacy, no urine culture. So it's that assumption that it's going to be a pathogen or that responds to nitrofurantoin, which is a really kind of like old, you're clinician, so I'll be slightly careful with what I'm saying, but it's a kind of like broad spectrum, very standard, very cheap antibiotic, which is just dished out to to everybody who meets this pathway. And for 20 to 30% of women, it just doesn't work. It doesn't work. And what we see is women going around these loops of antibiotic prescribing, and the antibiotics will become less and less effective, and the pathogens are becoming more and more resistant to it. So for women who get recurrent UTI, so again and again, like I did, the real fear for me was that I'm going to run out of antibiotics that I can take. And that becomes really serious, because then you start to, if you get a new infection, you start to go into how is this going to be managed? Am I going to end up with sepsis? And then, you just end up on these crazy pathways. So whilst pharmacy first is great for lots of women and it's the standard pathway, there's a significant minority of us for whom it doesn't work. And that really is where the system starts to let us down.
Yeah, I think that's really interesting, Catherine, that you've mentioned that. I was actually listening to a podcast not so long ago, which is about urinary tract infections from the point of a urologist. And he was saying that, in the context of recurrent UTIs, we really need to think as well, is it another infection, or is it an inadequately treated previous infection?
Exactly.
He was advocating for test of cure, or another sample being sent off to make sure that we are adequately treating infections before essentially labelling them as recurrent as well. And like you say, I think this will fit into the broken pathway conversation, but I think urine cultures can kind of sit in that as well. Why do you think that sometimes urinary tract infections are trivialized? Why do you think that we're maybe not taking them that seriously in some regards?
Yeah. When I read the question, I was thinking about it. The response that came straight to my mind is it's women's health, isn't it? So how many of our conditions, women's health conditions, are trivialized and not taken seriously? And I think, as I said earlier, it's women, it's older women, it's urine. So you put those three things together, and then you're creating this kind of triple. I think it's a problem at a national level, but more seriously, it's a problem which at a national level falls between portfolios. So nobody owns UTIs at a national level. So it sits between women's health, which, as we know, is overlooked and underfunded. We'll come on to the women's health strategy in a little bit. Urogynecology, which is underfunded itself. And a lot of urologists, I don't want to generalize here, but a lot of urologists are focusing on prostate cancer and are focusing on men. A lot of urogynecologists are male, and urology specialists are male. They're surgeons, so they're looking for surgical solutions. The surgical solutions for UTI hopefully are way down the line. For most women are not appropriate. And there's also an age thing here as well. So the prevalence of UTIs and the link to menopause is becoming more and more understood. And then we start to get into geriatric medicine, which again is so massively overlooked. So I think we've got a policy issue. Nobody owns it at a national level. We've got the fact that it's women's health, it's older women, and it's urine. So massive Cinderella issues. I think that you then bring in GP awareness. So how aware are GPs of what can be a really complex condition that requires early investigation, it requires self-education, it requires ability for women to manage their condition. And then it requires sometimes quite complex diagnosis and a range of pathways. And primary care just doesn't have the time, unfortunately, to do that. I think there's a couple of other things, is that we don't have a national strategy around it. We have a national strategy around antimicrobial resistance, which treating UTIs properly would make could make a significant contribution towards, but we don't have any kind of national kind of priorities around UTIs. And unfortunately, in the NHS nowadays, if you've got the stick of a national standard and a programme to work to, and then you've got the carrot of having some funding to be able to design new pathways, to be able to train GPs, to be able to train women as well, then that really helps. And then I think the final thing I'd say on this is that, like, if you want anything done after women, we're going to have to start advocating much more strongly for ourselves. I think we allow ourselves to be fobbed off by pharmacists who've got the best of intentions but are working within a restrictive pathway. We go to our GPs, we're fobbed off, we don't understand the condition well enough, so we don't insist on things like proper diagnostics, proper urine samples, proper cultures. No, it's come back. It isn't a new infection. It's the previous infection that has not been properly dealt with. So I think it's complex, but those would be the big drivers for me.
Yeah, makes sense. So what would a modern woman-centered pathway look like to you?
Yeah, I mean, it starts with all the the basics of designing any pathway, which is genuinely putting the patient at the center of it. Let's ask women what they need. And so that's what I would be doing. And there's a couple of organizations that are doing this really well. I wanted to give a shout out to Live UTI Free. So if people go and check out the Live UTI Free website, they're doing quite a lot of insight and research there into lived experiences. But I would take a typical journey, which is one, education, massive campaign of education, so that women understand and can recognize some of the symptoms of UTIs and can come equipped either into pharmacies or into their any kind of primary care professional, understanding a little bit more. I think there's also a huge amount that we can do with self-management. There's nutrition factors, hydration makes an enormous difference. Hormonal stages, so the link with menopause. So again, if we're aware of this, we can advocate for ourselves with clinicians and professionals. The next bit has got to be GP education. So if women are coming in asking questions, GPs need to be interested and to have some of the answers and to be able to signpost. And then the next bit for me is actually, if a woman is coming in with a UTI, then we need to do cultures. We need to do urine cultures. We need to identify what the pathogen is as quickly as we possibly can. And that means doing proper urine samples and doing cultures of some kind. And again, there's a range of things. We'll talk about innovation. You can do this at point of care, and you can do it in GP surgeries, you can do it in pharmacies. So we actually identify the culprit and prescribe the correct antibiotics, and do that really quickly before the infection takes hold. So those would be some of the big things for me. And then for the 20% of women who are not going to go down that pharmacy first route, so the nitro and trimethoprim doesn't work, then actually it's trusting us to manage these things ourselves. So GPs can be very reluctant to prescribe antibiotics, so that you have antibiotics with you, so you can actually treat your symptoms as soon as they present. But you have to trust us. We have to be trusted to be able to manage our symptoms effectively, even if that does mean that some women will have antibiotics and can use those when they need. And the other bit is really investing in treatment options and investing in research. So I'll give you a good example. When I had my horrendous kind of bouncing around pathways, I did some research and found that D-mannose can be absolutely brilliant in terms of taking D-mannose every day and using that as a preventative treatment. I found that my ICB, my integrated care system, didn't actually support the prescribing of it. So it was going through the process within their internal bureaucracy. So for my GP to be able to prescribe it to me, so the pathway would be educate women, give us the information we need, make sure that GPs have got a bit of time, or we have specialist services, identify the pathogen at the earliest possible stage, treat it properly with the correct antibiotic. And if it's not going to be a straightforward case, we need a different pathway that women can go on, which is not just going around these same circles again and again.
Just even a simple thing. So, for example, we send off a midstream urine, an MSU. Are we even telling people when we're giving them the
What is that?
sample pot, what is that? You know, how do you do a midstream urine? Because obviously we don't want to, pick up lots of contaminants or just skin flora when we're testing the sample. And I would say the basics, let's get the basics right. That's the real gold right there, isn't it? And like you were saying, Catherine, as well, I think sometimes we just need to dig a little deeper. And I think certainly if someone is presenting multiple times with symptoms of a UTI, I would say you need to see that person face to face. You need to get them in. You need to examine them. You need to take a full history. You need to make sure, because sometimes there are other things that can be going on. So let's make sure we exclude that as well. But let's give a full holistic management. So like you say, if someone is menopausal and they're getting a lot of UTIs, can they have vaginal estrogen? Would that work for them? Is there a need for that? And let's get the basics right. Let's treat people holistically and not be so responsive, because I feel that we've become very responsive in primary care of it's coming through as a telephone, a consultation, or even, kind of a message that someone has got a UTI, can they have some antibiotics? But we need to dig deeper, I think particularly with people who are coming with recurrent UTIs, because it is a real source of frustration for these women.
Yeah. I was just, I was struck by the point you were making about midstream urine samples, and that is so important. It's so important because I think every day matters. Every single day matters when you've got a UTI that starts as that horrendous burning sensation and the need to go for a wee all the time. After I'd had 4 UTIs within 2 months last summer, I went from that burning sensation to passing blood, going a kidney infection, and it gets faster and faster each time, was my experience. But it was actually only the 4th or 5th time that I was given a proper midstream urine sample, and I didn't understand why that was important. So I think the point you made there about not collecting flora from the skin and not collecting that first kind of concentrated flow of urine is really important. And there's devices out there that allow you to do that much more easily, rather than peeing in a urine pot where you wee all over your hands, and it's really horrible. And you can't get a midstream sample. It's impossible. But nobody explained to me how important it was to get a midstream sample. And there's innovations out there like PZ, for example, that are designed for our anatomy, and then make it really easy to get a midstream sample. So if you did that the first time that women fall off that pharmacy first pathway, it's that 20% of women that should end up back at their GP, that could have a really hygienic, clean midstream sample done, taking that couple of days for the culture to come back and getting the right antibiotic, could nip that episode in the bud, rather than like me going around 4, 5, 6 times and then ending up with multiple courses of antibiotics. And then of course I ended up with thrush. So it ruined 3 months of my life. And now I'm always on the alert to think, is this going to happen again? Just something as simple that doesn't massively change the GP pathway, that doesn't massively change things for women, but actually just getting those basics of how do you take a sample and how do you make that sample really work and save GPs money, because they're not doing repeat lab fees. It's just things like that. We have got the tools, we're just not implementing them in the right way.
Yeah. And which other innovations feel genuinely promising to you? You mentioned point of care testing. So obviously we're aware of the urine dipsticks that you can dip in urine, and that's a point of care test. So you can see, are there white cells? Is there blood? Are there nitrites in there? So you can kind of get an idea of whether somebody might have a urine infection from that. But you mentioned around point of care testing to look for what bacteria is in there. Does that exist at the moment?
There's some good innovations in this space. So Emma Hayward at Lucent is a good person to talk to. So she's a microbiologist, and she has developed a device that could be used either in the GP surgery or in fact could be used in a pharmacy, where you take a really small urine sample and it looks for the exact type of bacteria, so you can identify the exact type of bacteria there. And once you can see, so you can either rule out the fact that it may not be a bacterial infection. And Emma, I think that's really important when we're talking about older adults, older women in particular. So you don't want to be prescribing antibiotics if it's not a bacterial infection and actually the symptoms that you're seeing is something else. So that's a really important consideration. And then if it is, then actually being able to identify what kind of bacteria it is at that very, very early stage, if you don't have a contaminated urine sample, then that's really important as well. So she's doing some really interesting work that is being applied in care homes and is being applied in GP surgeries as well. So she's somebody, that's one of the innovations that I think could be really, really exciting and really interesting. And again, wouldn't necessarily need to change the pathway that much. That's the thing, isn't it? We're not asking for huge changes to the pathway. We're saying let's use the precision tools that we have at the point where women are presenting so that we can actually use the antibiotics. And Bayer have a new antibiotic out, haven't they, as well? And we can actually apply those more efficiently. So I think those things are great. And then we've got some vaccines that are being trialed. So again, if people go to the Live UTI Free website, they're recruiting to a clinical trial for a vaccine for UTIs. So there's quite a bit of work happening in that space as well. And then all of these things there could lead themselves to testing in the home. We're not quite there in terms of that point of care testing in the home in the UK yet, but there's a cohort of innovators that are looking at that space as well. Another area that I think is really interesting is self-management. So there's some work happening with quite a few apps in the space that are looking at recording your symptoms and looking at the frequency of your symptoms and looking at linking those with lifestyle factors, other things that's happening in your life at the time. And that's really interesting as well, because that kind of like diary management or symptom recording produces a ton of data that could be useful for GPs, if you're happy to share it, but also gives that insight into what is it that's triggering a for me at this particular point. And it isn't always the things that you might think it is. So there's a lot going on in the space that I think we should be genuinely excited about.
Yeah, I love the idea of someone being able to come in and actually be tracking. So I think, for example, the first thing that comes to me is, even some healthcare workers that are on call and them doing like 4 nights in a row, and they're not maybe looking after themselves as much. They're certainly not drinking as much.
Okay.
Would we see a link to potentially even shift patterns and them increased risk of UTIs? Because obviously I know that we talk about intercourse a lot as a risk factor, but it'd be really interesting to see more about certainly other aspects of lifestyle, and for us to just think a little bit more laterally about what's going on as well. So I think that's a really interesting, novel, way of us approaching it as well.
Mm-hmm. Yeah, absolutely. I think anything that gives us as women, that gives us insight, able to understand a range of conditions in the context of our lives more holistically is really interesting.
Shall we talk about the Women's Health Strategy? Katherine, can you tell us a little bit about it for anybody that's not heard about the Women's Health Strategy, what it is?
Yeah, so the Women's Health Strategy was published 3 years ago. And so it was the first nationally published strategy around women's health, and took in evidence from 100,000 women. So a huge number of women. Shows how motivated we are to get give the government insight on how we feel about our health. So 100,000 women responded to a kind of like survey asking us what our major concerns were and what we wanted to see change. So it's a kind of whole of reproductive life. There is a focus very much on reproductive life, which I think is a bit of an issue, but anyway. And it has a series of policy commitments, insights and policy commitments into a range of areas around women's health. And I was so excited. I was so excited when this was published. It's one of the reasons where I just went, right, okay, I really need to focus in on women's health here. I was so excited to read it. And then I realized that the word data appeared 3 or 4 times. The word digital appeared twice. And it came with a funding commitment of £250 million over 2 years, which in NHS terms is absolutely nothing. One of the major things to come out of the women's health strategy was setting up of women's health hubs. And essentially a women's health hub is either a physical or a digital location where a group of specialists can come together and women can come to one place and have a range of their concerns looked at. And then avoiding multiple visits to multiple places. So if you're pregnant, you could have a coil fitted soon after birth, for example. You can actually talk about menopause in the same space that you might come and see your GP for other reasons. So it's really exciting bringing together of a whole range of clinical specialties so that women can have a bit more of a one-stop shop. And it was brilliant. It was really exciting, except that each integrated care system had £280,000 per year for 2 years of non-recurrent funding, which was hugely disappointing in terms of the amount of funding that was put into this. What it did do, though, the clinicians who were really excited about this came together and did a huge amount of work to bring services together. And it's made a massive difference in the areas geographically in the UK where it's been taken really seriously. There's been some fantastic work done. Disappointingly, the funding has not been recurrent. And what's happening now is that Dame Leslie Regan, who's the most extraordinary ambassador for women at the centre of government, is revising that strategy and is looking at what the next iteration of it a couple of years on should look like. So she's in the process of gathering evidence and then saying, right, okay, this is what we achieved with the women's health strategy at a national level. This is where we should take the policy focus next. And I'm very much hoping and advocating very strongly that urinary tract infections should be a huge part of that. So in the way that we've achieved so much for menopause in the last couple of years, our focus should be on urinary tract infections and redesigning the pathways as we've described to enable women to be caught in that UTI journey as early as possible and managed in a much more holistic way so that we kind of like see a reduction of the impact of UTIs on women's lives. So it's exciting times at the moment. It looks as though it's going to come without funding, which I know Dame Leslie will be working really hard to advocate for funding to support this, because as you know, Emma, without funding in the NHS, it's really difficult to get any kind of new project off the ground.
Definitely. I think, yeah, it's really disheartening, isn't it, when you hear it as well about restricted funding or non-recurrent funding, because it kind of feels like it's stopped before it started as well, which I think is...
Yeah.
It doesn't fill people with optimism when, because a lot of the time as well, people don't know when that funding is going to be renewed. So it's normally very late, sometimes quite late in the financial year as well, when people know if they're going to actually have that funding again, which can also make obviously service planning very difficult as well, and kind of future proofing as well. So like you say, that the money is always a big problem. But it's great, isn't it, when we've got so much input from women and kind of hearing their voices and then being able to put forward their opinions. Do you think that we are taking them seriously in policy at the moment?
No, I would say no, because you need to look at the changes and what has happened. The lived experience of a majority of women would indicate that things haven't substantially changed. Although there've been some massive shifts, haven't there? Been some huge shifts of being able to get HRT on reduced cost prescriptions. Access to HRT has been amazing. So I think that is something that really, really has changed. I think changed massively. But then also sometimes I feel as though I live in my own little bubble, my own little bubble of women who are incredibly passionate about women's health and are making change happen at either a hyper local or a national level. So I sometimes wonder if I stepped out of that and looked at women's experience full stop, whether the changes have been as big as I imagine they have been. I think in menopause we've actually managed to get this on the national agenda. There've been some pretty significant changes from both the Treasury level all the way down. So I think that is good. And also, I feel that there's a lot more clinicians that are really committed to making change happen in women's health, and the strategy has helped to activate that. And when you've got the willingness of a whole bunch of clinicians and professionals, then things, mountains get moved with very small amounts of money. And I think that's where the change has happened in women's health. But at significant shifts, then I would probably say, no, we're still not listening. We're still not listening. And we're still not able, when people are listening, they don't have the resources to be able to make those changes.
Yeah. I mean, shall we talk a little bit about you, Katherine, as well? Because I think you've had quite an interesting journey across innovation, digital health, policy, well-being now. I mean, what actually first pulled you into the world of women's health?
So I've been a passionate supporter of women in the workplace, women in technology. My main career was in IT outsourcing and digital innovation in the corporate sector and financial services. And it always supported women, always been part of mentoring schemes. So for women to be able to be our best selves has been something that's been a part of my life forever. And then just before COVID, I didn't know COVID was going to happen. I thought what the NHS could do with some of my extraordinary ability to change the world. Let's go and work in the NHS. So my first job in the NHS was the Chief Digital Officer of an integrated care system. And just before COVID hit, so that was a bit of a baptism of fire in so many ways. And it was the women's health portfolio that I had that just completely just transfixed me, the ability, the need firstly, and then the ability to get things done. And I was just absolutely in awe of some of the professionals that I met in the space. And also the fact that if you solve health problems for women, you're solving them for her family. If you educate women around prevention, self-care, any kind of educating a woman is educating a whole section of society, because we tell our friends, we look after our families. And I just thought, actually, the way that we're going to make change happen societally is by really investing in women's health. And then the other thing was, like, the NHS and social care are 80% women. And if we really want to sort out workforce crises in health and social care, then we should be focusing on women's health, especially around menopause and older women, because look at the age profile of this 80%, then they tend to be older women, and we're losing 1 in 10 women out of the workplace, yada yada. So I just thought, actually, this is the one issue. If we can actually focus in on helping, some of the major conditions around women's health, we're going to help with the workforce crisis. We're going to help with the long-term plan of prevention, early diagnosis, and actually we're going to improve the health of a nation as a whole. And it just seemed like such a no-brainer. It's like, why isn't this the sole policy aim that the government has? Sort women out, because we're the ones who are sorting everybody else out. So it was a kind of extension of, like, women are the best things on the planet. We deserve better. To actually, the way in which we're going to deserve better is by being healthier. And then when I left the NHS, when things kind of slowed down, and it became around electronic patient record systems, which I have very, very little interest in either the strategy of or the implementation of, because it's like something that the rest of the world did decades ago, is getting decent systems of record in. So I left the NHS, and it was the amount of innovation, the amount of opportunity that there is to change things so significantly was just like that's my kind of crusading cape at both a policy level. It was great to work with the women's health team around, when the strategy was first published, to think about how we could implement digital, and then continuing there to say, right, come on, we need to change these things. So in a kind of like advocate and policy advocate role.
Brilliant. I love it. I think that's an excellent explanation. To be honest, like, it's a no-brainer. It's the best answer ever. It's a no-brainer.
Yeah, it totally is. And it totally is a no-brainer. I don't get it when we're going on about workforce crises in the NHS, and 80% of the workforce is female. 1 in 10 of them are going to leave, because of ongoing health issues and menopause in particular. It would just be like anybody, any junior analyst in any of the major consultancies would look at it and go, that's your biggest leakage of people. This is the problem you need to solve. And it's oversimplistic. I know it's oversimplistic, but it is such a good place to start.
Yeah. And we also, we have quite a lot of clinicians. We also have quite a lot of founders, and we have quite a lot of want-to-be founders that listen to the podcast. And I know you've got experience as an advisor for health tech companies. What do you think that founders often get right, and what do they commonly overlook when they're designing for women?
Well, I think there's a bit of a gender divide there, and I would say that, and this is so simplistic. This is so simplistic. So I'm sure your listeners will be throwing their hands up in the air and just going, "This woman's being so simplistic." But I think lots of male founders tend to try and solve point problems without looking at the context in which these problems are occurring. So that tends to simplify solutions. So that would be one thing that I would say is, and I think a lot of founders will think about how they solve the problem for the individual rather than how that problem gets adopted and solved within the wider health ecosystem. So you can do something that's absolutely brilliant for patients, but if it ends up being a burden for the clinicians in hospitals, as in it's another app that they have to download, it's another set of data that isn't integrated into your EPR, it's another thing that you have to do on top of lots of other things that you have to do. So that kind of like whole system approach is something that I see people getting wrong again and again and again. There's a couple of other things, is that some problems are massively impactful, but they can't be solved with technology. And I think that is another thing. I do a lot of assessing for grants, so I see lots and lots of innovations there. And they assume that tech can change stuff, and quite often tech can't. It's not a problem that technology can solve. It's something that requires a lot more education. It's something that requires genuine behavior change that needs investment more widely in terms of supporting people to make changes in their behavior. And having an app on your phone doesn't necessarily mean that you're going to change your behavior in any kind of meaningful way. So I think that obsession with technology can solve health problems needs to be looked at, especially, and this is a bit of a hobby horse of mine. I think we take some real risks in digitizing some health monitoring tasks, especially if the individual thinks that a clinician is looking at the data at the other end. So if I were to leave hospital, or I were in a virtual ward and I was wearing some kind of, I had some kind of wearable that was collecting data about me, my assumption would be that somebody was actively monitoring that data at the other end. And if there isn't, if that monitoring isn't happening and those guardrails aren't there to see when data goes out of norm and intervene, then I think we're actually creating a ton of clinical risk for people.
You are opening up a can of worms, because Emma could go on about this forever. I'm not joking.
It's just like hearing my own voice reflected.
Emma, we do not have time. We need to wrap up, Emma.
No, I know. Katherine, we will touch base on this another time, because you've definitely got someone on your side there for sure. Yeah, I'm kind of like, if the data's there, it's there. So if it needs action, somebody's got to do something with it.
Don't close your eyes to it. Don't just grey it out. When the extremes, I'm going to go off on one. When the extremes are greyed out and it's not our problem, it's fine. It's too high. It's too low. It's not our problem. We just won't talk about it. And then we're not a medical device. It drives us absolutely balmy and up the wall here. So yeah, but we won't open that can of worms, because we will be here for another podcast.
Yeah, put the lid back on that. Let's talk about something much more positive. Let's talk about something much more positive, because we have just seen the most incredible view, Katherine, before. Please tell us about your new women's retreat in India, because it sounds amazing. It certainly looks gorgeous over there. So what is it that you are creating over there?
Yeah, so this was kind of like one of those serendipitous accidents. In a way, I'm in a very, very fortunate position that I can work remotely for a number of months of the year, and was in India on a women's health charity trip with an amazing bunch of women. We drove rickshaws across India, which was just crazy, 60 of us. And I ended up in Goa, and I ended up meeting the owner of a yoga retreat, really beautiful yoga retreat here on the beach in Goa. And I was talking about connecting the ecosystem of female founders in the UK with female founders in India. And I was also talking about the need to have a much more holistic look at women's health, and yoga being part of it, meditation and kind of like mental well-being, relaxation being a part of it, nutrition being a part of it. And then of course looking at, thinking about medication and more traditional medicine as well. So I was kind of like going on about this, getting all excited. And he said, well, why don't you use my place and do it? So why don't you just, crack on, see if you can make it happen? So in October of last year, I came out here for the season, learning to run a yoga retreat. So what I want to do here is bring together a much more holistic view of women's health, thinking about, and I'm thinking in particular about perimenopause and menopause as a life stage. So thinking holistically about the factors that can impact on how detrimental perimenopause and menopause can be to women, and the impact of it, and how we might be able to modify that impact. So that's thinking about factors like nutrition. It's thinking about factors like exercise, yoga being an incredible way to start build some strength and flexibility, but also bringing in things like weight training and other areas that are super important to our physical health. Also thinking about relaxation, mental health, and mental well-being through community, and bringing in interventions that are not woo-woo. So we're not talking about steaming our yonis here. We're talking about thinking about nutritional supplements. We could be thinking about hormonal supplements. We could be thinking about a whole range of interventions, both medical and digital, that would help us kind of like think about what the right components that we can select to bring together to get us through what can be quite a challenging life stage, and then do it surrounded by monkeys and woodpeckers and the sea, and maybe integrate that as part of a holiday. That's the idea. So there's a consumer facing one, but then there's also, what I'd love to do is bring a group of women's health professionals together and think about how we can create our own possibly women's health hub, and have that as a package that you could have over here, or maybe bring back to the UK. So there's so many possibilities. There's so many possibilities around it. So this is my kind of practice year, bring it all together, and then hopefully do something very early in the season next year, which will be around September time. So it's a kind of watch this space, and if anyone wants to talk or has ideas around it, then I'd love to listen.
It sounds really exciting, Catherine. It sounds like you say, it sounds like there's so many possibilities where you could take it, which is it's a great place to be, isn't it? Where
Yeah.
where kind
And
of possibilities are endless.
no yoni steaming. So
Yeah.
big win from us.
Honestly, the stuff that people do out here is crazy. I don't think the stuff that people do out here is crazy. You can do a course on absolutely everything. And I did see a 2-day yoni steaming thing, which sounded painful and possibly slightly dangerous. So maybe wouldn't advocate for that one.
So for people who would want to get in touch with you, Catherine, you just said, if people want to reach out to you, what's the best way that they can contact you?
LinkedIn. LinkedIn is really good. Well, LinkedIn is terrible given the censorship around women's
Yes.
health conversations and the algorithms. But that might be another thing we wouldn't delve into. But LinkedIn's, I still think it's a good platform. So reach out to me on LinkedIn.
If we start talking about women's censorship, Catherine, I'm going to have to gag Claudia, because we will we will be talking again, because again, it's up there, isn't it, Claudia, on our
Yeah.
on our multiple injustices that we're going to keep kind of banging the drum about, I think.
So where somebody must be working on an alternative. Somebody must have something in beta or about to launch as an alternative to LinkedIn. Because there's so many people, and it isn't just women. There are so many people that are getting hacked off with it.
But yeah, I've heard along the grapevine that there are some things being built by some people, but that is all I can say. So we will watch this space as well.
Yes.
Yeah, but thank you so much, Catherine. Thank you so much for your time, for showing us the beautiful landscape, and yeah, we'll be following and seeing what happens. Maybe you'll find us in India.
I would love that. I would absolutely love that. You're exactly the kind of clinicians and women's health specialists that I would love to have out here.
Could we do an episode from there? Could we live stream an episode from there? That would be amazing.
We have the most stunning, gorgeous pineapples here. They're little tiny, little small pineapples. They're the sweetest things you will ever come across. So I'll supply the pineapples and you bring
Fabulous.
yourselves in the audience.
Thank you so much, Katherine.
Great.
Have a good day. See you.
Bye.
See you. Bye.
Thanks for being here. We love having you with us on this journey through women's health and innovation.
Follow us on Instagram at the Pink Pineapple Podcast for clips, conversations, and the latest in women's health and femtech.
We'll see you next week. Same pineapple, new topic. Everything we talk about on the Pink Pineapple Podcast is here to inform and inspire, but it's not a substitute for professional medical advice. If you're worried about your health, please reach out to your GP or healthcare provider.